Okay, we've given everyone about a minute or two to hop on here, so I think we'll go ahead and get started. Um, my name is Jenny Lancaster, and I will be your moderator today. I just wanted to thank you for joining us for this session, and this is Identifying Prescription Drug Prevention Needs and Resources with KTRACS. I'd like to start with a couple of reminders. The session is recorded and will be available on the conference platform 1 hour after this session ends. If you could please keep yourself muted unless the presenter asks otherwise, and make sure to join sessions live today because we will be doing a prize drawing from attendance within each session. And the conference is also offering free continuing education credits. And so for more information, you can visit the continuing education page on the platform. So I'd like to introduce to you Gail Donaldson. She is the Public Information Officer for KTRACS, the Kansas Prescription Drug Monitoring Program, which is a division of the Kansas Board of Pharmacy. She's responsible for developing communications and identifying and creating educational opportunities for the state's healthcare providers. Gail, I'll pass it over to you.
Thanks, Jenny. Well, I appreciate all of you joining today. We'll just dive in. So if you are not familiar with KTRACS, it is the Kansas Prescription Drug Monitoring Program. And how this works is pharmacies are required to report controlled substance dispensations. So we're talking about Schedule 2 through 4 controlled substances, opioids, stimulants, and benzodiazepines. We require those pharmacies to report that information to KTRACS within 24 hours of the patient actually receiving that medication. We've also defined a few drugs of concern in state law that we want to track as well, and so pharmacies are required to report those too. This applies for all Kansas residents, regardless of where their prescriber is located or where their pharmacy is located. If they have a Kansas address, that information is required to be reported to us. So that is the requirement side of KTRACS, the information coming into our database. Everything that goes out is voluntary. So prescribers and pharmacists throughout the state have access to KTRACS. They can register for a free account at any time, and they can go in and they can query patient prescription history as part of their clinical decision making. And so all of that is completely voluntary. We do have over 14,000 users across the state who are using this information in their clinical practice. At KTRACS, we're basically a database of information, and so we can't act on our own to accomplish our program goals. We really rely on the healthcare providers to help us. We hope that our program helps healthcare providers prioritize patient safety, promote community health, prevent prescription drug misuse, abuse, and diversion, and preserve legitimate access to controlled substances. We hope that you at a community level can help with those middle two goals of promoting community health and preventing prescription drug misuse. And so today we're going to talk a little bit more about controlled substance prescribing trends across the state and looking at it at a county level. How you can use KTRACS information to inform your community prevention priorities. We're going to talk about some ideas for engaging your local healthcare providers in prevention efforts surrounding prescription drugs. And we're going to talk about harm reduction strategies related to naloxone and safe medication disposal. If you would like to kind of follow along and look at what's happening in your local community, you can go to this page on our website, ktracs.ks.gov/county data. And you can download your own county fact sheet. All counties are available. You can look at your county, you can look at neighboring counties, and you can kind of see how trends are going in your county as we talk about some of the statewide trends as well. So when we talk about controlled substance prescribing, again, we're talking about prescription opioids, which are prescription pain medications, prescription stimulants, mostly used for ADHD treatment, and then prescription benzodiazepines, which are used for anxiety and insomnia. And so as we look at the trends here, we see a 15% decrease in all controlled substance prescribing over the last 5 years. And primarily, as we talk about this information today, we have kind of filtered this information down to only Kansas patients and only the prescriptions that they're getting from Kansas prescribers. So those are our parameters. This map takes a look at what is the percentage of individuals in your community that have had at least one controlled substance prescription. And this is for the first 6 months of this year. And so it's very possible that someone in your community had a very short prescription for a prescription pain medication after a dental procedure or something along those lines. You know, you get your wisdom teeth out, or I've never had a root canal, but maybe you get pain medication for that. Whatever it might be, some of those acute type situations where you have short-term pain. So the number of people in your community who have had a controlled substance prescription, it could be one-off prescriptions like that, or it could be people who are on long-term therapy with these types of prescriptions. And so this kind of just gives you a look at, if I'm walking down the street, what is the percentage of people I meet who may have had at least one controlled substance prescription this year? What's the sheer volume of prescriptions in my community? So you can kind of see there's quite a bit of variability in the state, but you do see a little bit darker areas on the map there in Southeast Kansas. And you're going to notice that Southeast Kansas shows up pretty prevalently on some of the maps that I'll show you today. When we talk about opioid prescribing specifically, we're looking at a 26% decrease over the last 5 years in opioid prescribing in the state of Kansas. Does KTRACS have an impact on that? Yeah, we absolutely think that it does. Are there a lot of other factors at play in reducing all controlled substance prescribing and reducing opioid prescribing specifically? Absolutely. But we like to think that KTRACS at least has some positive impact on this. And so you can see the numbers decreasing there. If you look at the yellow line, this is the average daily MME levels per prescription over the last 5 years. MME stands for morphine milligram equivalency. And basically what that means is we're able to take all the different types of opioids, hydrocodone, oxycodone, morphine, prescription fentanyl, tramadol, all these types of opioids, and put them kind of on a level playing field. There's a conversion factor that you can put in there so that you can say this dosage of a hydrocodone equals this dosage of an oxycodone. So it really just allows us to compare apples to apples when we're looking at opioids. And so you can see there that on that yellow line, the average daily MME level has dropped from 57 to 44, which is positive news because, as I show you this, in 2016, the CDC came out with Opioid Prescribing Guidelines for chronic pain, and they said that prescribers should use caution when increasing opioids to greater than or equal to 50 MME per day. And so when we look back at this chart, we were above that 50 MME level on average 5 years ago, and so we've come down below that threshold now. They also suggest that prescribers should avoid or carefully justify increasing dosage to greater than or equal to 90 MME per day. There are absolutely clinical reasons for prescribing at that level, but that's kind of a threshold that we consider to be high risk prescribing. And you can see some of the recommendations that the CDC made when patients are receiving opioid prescriptions at that level, one of them being considering offering naloxone. And so this map, you can see here that this is a percentage of all of the opioid prescriptions being dispensed in the county that are at or above that 90 MME level. And so you can see that we range quite a bit. And there's a lot of factors at play here. You know, there's a lot of things we don't know about these prescriptions. Specifically, we don't know what the diagnosis is. What are they actually being treated for when they are receiving these opioids? And so we know that there are a lot of labor-intensive jobs in rural areas of the state that lend themselves to more injuries, which may lend themselves to more treatment of pain. And so there's a lot of different factors at play, but this is just a good idea of, you know, when we're talking about opioid prescribing, this threshold is one that has been established by the CDC as something that we should pay special attention to. So that's kind of why this is included today. When we look at opioid prescribing by age group, you can see that prescribing has been declining at about the same rate as the statewide average for all of these age groups. You can also see that in 2020, 46% of all of the opioid prescriptions in the state of Kansas went to baby boomers, ages 55 to 74. And when we take a look at that age group, 46% of all of the prescriptions are going to that age group. 54% of all of the what we call the high risk opioid prescriptions at that 90 MME level or higher are also going to this age group. And that matters because as we age, our bodies change, our metabolism slows down, our ability to process those medications slows down. And so the potential for buildup of medication in our system is there. As we age, we experience different things in our life, like retirement and empty nest syndrome, and all of these things that could really factor into mental health. And then as we age, we tend to develop more chronic conditions. That's just kind of how life goes. And so as you develop more chronic conditions, there's a potential to be taking more medications to manage those conditions. And there's always the potential, the more medications you take, for adverse drug effects, and especially if you're combining them with opioids. So that's kind of why we take a look at that baby boomer age group and point out just the sheer volume of prescriptions that are going to that age group. Last year, KDHE partnered with Tufts University to develop an opioid vulnerability assessment. And you can see here, we talked a little bit earlier about highlighting the southeast area of Kansas, and you can see they're highlighted here too. This assessment looks at the risk for opioid-related mortality. And they looked at a number of factors at play and decided on the core indicators that you kind of see on your screen there, factoring in opioid overdose deaths and non-fatal visits to emergency departments, opioid prescriptions, drug-related crime, hepatitis C cases, and median income. And so the counties in the maroon with the bright red outline, those are the counties that were assessed as being at elevated risk of individuals experiencing opioid-related mortality. And so you can see that concentration in Southeast Kansas. There are also some metro areas, Topeka and Salina are identified here. And there are also some rural areas of Kansas where, you know, we focused at a state level, we focused on a lot of prevention efforts in Southeast Kansas, but we don't want to forget that there's definitely increased risk in many other areas across the state too. And I think it's important for everyone to be kind of cognizant of what's happening in their communities. When we take a look at prescription opioid-involved overdose deaths, in 2016, the number of prescription opioid-involved overdose deaths comprised a little over a fourth of all of the drug overdose deaths in the state. In 2020, that's down to 15%. It's not that the number of prescription opioid-involved overdose deaths have decreased that much. There's been a little bit of change, but not a lot. But it's the sheer number of drug overdose deaths in the state of Kansas that are increasing. We went from 309 to 477 in 5 years. And so we've seen substantial increases, as Adrian talked about this morning, in the number of specifically illicit fentanyl and methamphetamine overdoses. And so that's contributing to those massive increases, but prescription opioid involved overdose deaths really haven't changed a whole lot over the last 5 years. Men and women account for about equal parts of those numbers of overdose deaths. And in 2020, you can see the age breakdown on the right-hand side there. So half of the prescription opioid involved overdose deaths occurred in the age groups of 25 to 44. But when we look at prescribing, only 17% of prescriptions went to those age groups. So it's really important. So we talked a little bit about baby boomers and that older adult age group earlier. But it's also important to note where the deaths are occurring related to prescription opioids. And of course, I'm sure, I think every session has probably talked about naloxone to this point, but you know, we do want to highlight naloxone, or Narcan. It's an emergency opioid antagonist that can reverse the effect of an opioid overdose within 2 to 5 minutes. It is absolutely not a replacement for emergency services, but it can help buy time for EMS to arrive. Administering naloxone and calling 911 go hand in hand. Like Jenny said in my introduction, KTRACS is part of the Kansas Board of Pharmacy, and the Kansas Board of Pharmacy has a statewide naloxone protocol that was established a few years ago, and it allows pharmacists to dispense naloxone without a prescription from a prescriber. And there are some clinical indicators that pharmacists are able to use in their decision-making about dispensing naloxone according to the protocol. And I really want to call your attention to the last 2 bullet points here. One being a voluntary request from a caregiver. Probably the most important thing that could be considered in giving someone naloxone and giving someone access to naloxone so that they have it is making sure that they have someone who can actually administer naloxone to them should they experience an overdose, because it's obviously not something that they can do if they're experiencing the symptoms of an overdose. So if there are caregivers, if there are spouses, children, neighbors, home health workers, whoever might be available that is with this particular patient or checking in on the patient, that voluntary request from a caregiver, pharmacists are able to dispense that naloxone. So it isn't even something that it has to be dispensed to the patient. And the second point there is patients who have difficulty accessing EMS. In rural areas of Kansas, I think that is absolutely applicable. I'm thinking about where my parents live. It could take 30 minutes for an ambulance to get there, without a doubt. When you're looking at rural areas of Kansas that have volunteer fire departments and very few EMTs on staff and who might be just on call versus sitting in a station waiting for a call, it can take a while. And so if you have those patients who are in very rural areas and it might take a while for EMS to get there, naloxone is absolutely a great idea. And that's one of the clinical indicators where pharmacists are able to dispense that medication. This map shows the availability of the potential availability of naloxone according to the protocol. And so and I think it's been highlighted in some other sessions, but this protocol is pharmacist specific, meaning it's person specific, not pharmacy specific. And so if you walk into the pharmacy and only one pharmacist on their staff has signed the protocol and that person doesn't happen to be working that day, then you would not have that availability. So this just gives you an idea of locations where there are at least one pharmacist on staff at these pharmacies where you could access naloxone. Another important point on naloxone availability is, it can expire. It's hard to stock. It can be expensive for a pharmacy to stock, not knowing how often they may dispense it. These are barriers that we've heard to access in the past. And so these are things that we would encourage you at a community level to work through with your local pharmacies. And so, what can you do? I think Safe Streets Wichita talked earlier. They actually sent out a letter to all of the pharmacists in their community, asking them to sign the naloxone protocol and giving them reasons why, giving them scenarios of what's happening in their communities. You could absolutely do something very similar in your community. Do you have some type of opioid stewardship committee within your hospital, within your local health department, within your healthcare community, where you can talk about naloxone co-prescribing? You can monitor opioid prescribing trends. You can offer prescribers education with regards to opioid prescribing and pain management. What are you doing at a community level to kind of take a look at the use of opioids in your community? Can you educate and train your community on the benefits of naloxone? Half the battle is the stigma associated with naloxone. And so can you do things within your community to educate people about what naloxone is, and maybe most importantly, what it isn't? Maybe even educating people in your community about what an opioid is and what it isn't, so that you can try to overcome some of those stigma barriers. DECA obviously has a free training program where you can either individually or as a group or as a community request training for how to administer naloxone. So that's a really good resource for everyone. So we've talked a lot about opioid prescribing, and I think there are some comments in the chat. So maybe we'll take a little break here before we switch gears to different drugs and try to answer some of those. I think, so Lisa's question, what year was KTRACS implemented? It was established by state law in 2008, but we didn't actually fully start collecting prescription drug information until 2011. And then is there another way? Okay, so Kathy's question is a really great question. This is a patient matching issue. And we, if you will, I have my contact information on the last slide, and if you will drop me an email with maybe some identifying information in these patients, we can take a look at that. Because we do have to, at times, do some patient matching and figure out, is this person the same person as this other person? We look at birth dates and addresses and that type of thing. And sometimes there are problems with siblings and twins and that type of thing, where the system can get a little confused and think they're the same person when they're really not. And so if you can maybe drop me a line afterwards, we can take a look at that particular situation. Yeah. Okay.
I think that's all the questions from the chat now.
No, great questions. Okay, so we're going to switch gears. We talked a lot about opioids, and in the grand scheme of things, we always talk a lot about opioids because that's where the national attention has been over the last 5 to 10 years, looking at the opioid epidemic. But we also track other types of drugs within KTRACS, and so we want to make sure that we're highlighting some of the potential areas where you might be interested in community prevention efforts. So benzodiazepine prescribing has been decreasing by 15% over the last 5 years. And benzodiazepines, again, they're things like Xanax, Valium, that type of thing. And if you were, there was a presentation earlier about novel benzos, which is just kind of mind-blowing that now we have to worry about those types of non-prescription type benzodiazepines out there. So we'll look at this by age group. You can see decreases across all of the age groups. We highlighted baby boomers earlier, this 55 to 74 age group. And we talked about 46% of all of the opioids in the state of Kansas are being dispensed to that age group. About 40% of all the benzodiazepines are being dispensed to that age group. And even though we're seeing decreases here, that's concerning because opioids and benzodiazepines tend to have the same effects on your system, very similar to alcohol. Which all three of those definitely should not be combined. And so we kind of have to pay attention to, what kind of education are we giving our patients about the medications that they're receiving? Are we checking KTRACS to see, are they taking both types of medications? And trying to maybe eliminate one to really keep patients safe. So that's kind of why we take a look at where are all of the medications being dispensed, what age groups are receiving those medications. In Kansas, we saw the largest number of benzodiazepine-involved overdose deaths ever in 2020 with 63 overdose deaths across the state. And I think it's really important to note here that that's not necessarily a mutually exclusive number. Very possibly those benzodiazepine-involved overdose deaths also involve an opioid. Depending on what state's data you're looking at or what research you're looking at, I've seen anywhere from 10 to 30% of opioid involved overdose deaths also involve a benzodiazepine. And so again, focusing on that combination is important. We saw that men and women account for about half of the benzodiazepine involved overdose deaths. And when we look at age groups, again, we look at these younger age groups. So we have age 15 to 34 account for about half of all the benzodiazepine involved overdose deaths in the state of Kansas. And the age groups don't quite align, but age 18 to 34 account for only 10% of all the prescriptions of benzodiazepines. So again, we have to think about, what kind of patient education do we need to do? What kind of prevention efforts should we do? What age group should we be focusing on? And again, you at the community level, hopefully know your community well enough to know where your focus should be. Again, this is all state level information, but hopefully your county fact sheet, if you were able to access that, can help you identify kind of more local trends. Stimulant prescribing. Stimulants are generally ADHD medications like Adderall and Ritalin. And so we've seen an 11% decrease over the last 5 years in stimulant prescribing. The peak of opioid and benzodiazepine prescribing was in 2016, but stimulants peaked a little bit later. We've seen them come down with the other controlled substance prescriptions as well. But we did see a peak there in 2018. When we look at stimulant prescribing by age group, you can see how this has changed. When I think about stimulants and ADHD medication, I'm thinking about teenagers and young adults. And I think, a lot of people probably have that association, but we're actually seeing significant declines there. Part of that could be due to the pandemic and students going home and doing remote learning and not going to school anymore, and maybe not needing those ADHD medications without so much stimulation in the schools. I don't know, that's all hypothesis, but it is interesting to note the increases that we're seeing among a little bit older age groups in that 35 to 54. And that's interesting because it's very possible that those 35 to 54-year-olds also have a teenager at home. And so we're going to get into some prescription drug misuse information here in a second, but it's just always interesting to see, where the prescription's being dispensed, but also thinking about who are those individuals and what kind of characteristics could those individuals have? What kind of education do we need to be doing? And I bring up that teen and kind of parent age group comparison because if you're not familiar with the Kansas Communities That Care survey, it's a really wonderful tool in terms of knowing what type of substance use prevalence there is among Kansas teenagers. And they do the survey every year, and there's some really good data in there. And this year's survey showed that 6% of Kansas teens report using a prescription drug that was not prescribed to them in their lifetime. And of those, 77% said that they got the prescription drugs that they used from a friend or family member, meaning they bought them from a friend or family member, they took them, they were sold them by a friend and family member, they were given to them. It was someone they knew, so they had pretty easy access to it. And actually 17% of the Kansas teens reported it would be very easy, or at least sort of easy, to obtain prescription drugs not prescribed to them. We've talked a lot about educating patients about what their medications are. Do they know what an opioid is? Do they know what the risks are? Do they know what the side effects could be? Patient education type things. But there's also, along with safe medication use, there are other factors like storage and disposal that we're going to talk about now. And so with safe medication storage, we recommend that you store medications in a locked cabinet, lockbox, or safe. Bathroom is not necessarily a good idea because some medications don't do well with humidity and that type of thing. So you want to keep all your medications together, keep them locked up. A kitchen cabinet, a closet, a lockbox of some sort would be the best idea. Childproofing is obviously not enough. It might be for very small children, but for older children or even adults who are in your home, who might be looking for something, that childproofing is easy to get around. And one really important thing that's very hard to communicate is it is illegal to share medications. That's a very hard point to get across to people because they think, well, I take this opioid for, my back pain, and oh, my husband had some back pain today, and so I just gave him a couple of my pills because I figure if it helps me, it should help him. And really, that is not what we want to see. That technically is illegal, and it absolutely is a safety concern because that medication was prescribed to you in your special circumstances, and that may not apply to your husband or someone else that you may want to share medications with. And so framing that message so that patients and people in your community understand that sharing medications is not okay is really important. One of the ways that we want to reduce the amount of medication that's in our community is reducing the amount of unused medication. And that really boils down to, our prescribers giving out a 30-day supply of a drug when you really only maybe need a few days, especially if you're having, we talked about the dental procedures, maybe you broke your wrist, maybe you're having some other type of surgery, and you're probably only going to have pain for a few days. And I think years ago, it was pretty common to see you get a 30-day supply no matter what. But because of the CDC prescribing guidelines and because of the attention that's been placed on opioids in the last few years, we've really seen a shift from that. And so the CDC guidelines say that when opioids are used for acute pain, prescribers should use the lowest effective dose of immediate release opioids, prescribe no greater quantity than needed. 3 days is often sufficient. More than 7 is rarely needed. So I've picked out some specialties here of Kansas prescribers. So you can kind of see, we're kind of in that 3 to 7 days supply range for most of these specialties, where they're for the most part treating patients who have that acute pain, that very short-term pain. And you can see the percentage of their prescriptions that are less than or equal to 7 days supply. Dentists are almost 100%. Emergency medicine right there at 90%. So, and then surgery is obviously going to vary based on the extent of the surgery, but they seem to all kind of be doing a pretty good job with that and limiting the amount of medication that's just sitting in a medicine cabinet unused. So what can you do with that unused medication? I'll start with the DEA drug take back days. This is a biannual event. It's usually the 4th Saturday in April and October. So we just had one a few weeks ago. And on October 23rd, we had 66 sites in Kansas take back medications, unused medications from individuals in the community. Over 7,000 pounds were collected across the state. This is a really great opportunity for law enforcement agencies to provide this service to their communities. Not all, sometimes the law enforcement agency partners with a pharmacy. Sometimes a first responder agency gets involved too, fire or EMS. But law enforcement does have to be involved in order to take part in this. And this is a really great opportunity, but it does only happen twice a year. And so at the Board of Pharmacy, we have the Kansas Medication and Collection and Disposal. I always put the "and" in the wrong place. Medication Collection and Disposal Program that is at Kansas pharmacies that allows individuals to dispose of unused medications basically at any time that pharmacy is open. And I apologize for the very small green dots here, but this map shows the medication disposal sites in Kansas at Kansas pharmacies. And so much like the naloxone map, you can see that there are some gaps in our state, especially in rural areas, in terms of being able to provide this service for patients. And there are things that come with it. There's a lot of regulations around being able to provide this service and being able to dispose of those medications correctly once they're turned over to the pharmacy. And so, there's some red tape that pharmacies have to work through, but you can obviously see we have over 100 pharmacies in Kansas that are participating. And I think it's really important to note too that I believe that 103 out of our 105 counties in Kansas actually do have a pharmacy located in their county. So that just gives you an idea of what we would like to see in terms of the dots located on this map. So what can you do? Again, talk to your local pharmacies about medication disposal options. Maybe even talk to your first responder agencies, because when we think about those rural areas of Kansas, does it make sense does it make sense to make patients come to a central location to dispose of their medications? Or does it make more sense that they're provided ways to dispose of their medication at home or through some mail-back program? All of these are options that are out there. And so, look at your community, look at your community needs, and talk to those healthcare providers and those first responders about what option might be best and how can you go about it. There are always some community grants that come available, sometimes through even KDHE and KTRACS. They sometimes involve medication disposal. So be on the lookout for those if that's something that you want to do in your community and you'd like a little bit of funding to be able to do it. And we encourage you to implement safe medication use messaging among the at-risk groups that you find in your community. We've talked a lot about baby boomers. We hit on teenagers and their parents a little bit earlier too. And so in your communities, figure out what at-risk groups do you want to target? What are your priorities for preventing prescription drug misuse in your community? At KTRACS, we've tried to help with this a little bit. We have a toolkit of patient education information that is free. You can download it from our website. There's a number of patient-facing materials that are available in English and Spanish that can be downloaded and then disseminated however you please. There are also some, and most of those materials focus on medication safety, opioid safety, and stimulant safety. There are also some tools that a prescriber or a pharmacist could use. They're pocket guide, checklist type things that healthcare providers in your community could use as well. And so we would encourage you to go on our website and take a look at that if that is of interest to you. So I told Jenny when we started that I talk really fast. So I would be happy to take questions. I think there are some more questions in the chat, and I would be happy to take those as well. Okay, so I'm reading Barbara's question. We leave the clinical decision making up to the physician. And so if a physician chooses to prescribe pain medication for long-term use, we assume that they have evaluated that patient and they have made that clinical decision in the best interest of the patient. That's what we encourage them to do. There are all kinds of options out there that can supplement prescription use in terms of treating pain. That's been a big focus in the opioid epidemic, is looking at non-opioid treatments for pain, non-pharmacological treatments for pain. And so, again, we leave that clinical decision making with that physician. Nothing I've presented here says someone's doing anything wrong. It's just kind of looking at, these are the guidelines that have been put out, and here's how our prescribers are doing. Every patient is different, every scenario is different, and we don't have diagnosis codes to be able to assess, why someone might have prescribed an opioid or not. So I hope that answers your question, Barbara. Jennifer's question about checking KTRACS required. So actually, okay, so Kansas Medicaid implemented some new rules on October 1st, and they require that prescribers check KTRACS before prescribing for a Medicaid patient. So that's kind of the first step. There's no way to tell in KTRACS if someone is a Medicaid patient or if someone is a Medicaid provider. Only Medicaid really knows that information. So I would assume that a lot of prescribers have just started checking it as a routine anyway, so that they don't have to sit there and say, oh, is this a Medicaid patient or not? So that's really the only thing that has become required. We are not having any conversations internally about making about a mandatory registration or a mandatory use. That would require legislative change, and that's not something that we are discussing internally, at least. Dr. Warren, yes, there is. It does show payment type for prescriptions, and I'll tell you that it leaves a little to be desired at times, I think. Just because, yes, sometimes it's wrong. That's it. And so we're actually looking at our data quality, and that's one of the initiatives that we have going forward. I was just in a session with the Missouri Hospital Association, and he talked about good data in, good data out. And that is really a good focus of ours over the next couple of years. We just did a strategic plan, and compliance and data quality are two of our primary initiatives there, because we do want good data in and we do want good data out, and we don't want to have to say that sometimes the insurance type is wrong, because sometimes it is. So yeah, if anybody wants to open up their mic and ask any questions, I'd be happy to do that too.
Hi, this is Lisa Veda, and I'm a pharmacist, and I was going to type all this out, but you said I could ask it in person. I have a physician that's new to the area, and they were asking me, does KTRACS track when physicians log into KTRACS? That this physician said in California that they're very picky about.
Yeah, so KTRACS does.
Yes, they do.
Technically, I think it probably tracks login activity. We don't really care about login activity, because if you log in, that's good for you. What we care about is checking patients. And so we can track, did a prescriber check a patient at what time, how many times, that type of thing. That is all available to us as part of our audit trail. But again, there's no requirement to do so. unless
Okay,
you're.
well, they were just asking more for HIPAA reasons that, you know, that where they were at before that they were, so, you know, you can't go in to look up to see if your neighbor or if a family member or something like that, that there are HIPAA issues with that.
Yeah, and we have some appropriate use guidelines for KTRACS that say that you shouldn't search yourself, your potential employees, your family members, that type of thing. You should only use KTRACS for medical and pharmaceutical reasons.
Okay.
Good question. Any other questions? Okay.
Okay. Oh,
Yeah, I think Marsha's got a great point there. Use KTRACS on a need to know basis. This is your patient, you need to know. If it's not your patient, you probably don't. All right, Jenny.
yes. Well, it sounds like all the questions have been answered. If anyone does have any other questions that you think of, you might just take note of Gail's contact information here. And like I said, this session recording and the other sessions from today will still be available on the platform. And this particular one will be available in 1 hour. So you're welcome to revisit those. And that way, if you had any questions that you wanted to go back and look at the information, you will have that opportunity. So thanks again for joining us today. And
sorry, Marsha threw one more question in the chat. I want to.
Oh, yes, absolutely.
We actually discourage printing out a KTRACS report to put in the patient's record. We would encourage you instead to just document in your notes that you check KTRACS, what you might have found that day that led to your clinical decision-making, that type of thing. We discourage you from printing it, putting it in the patient chart, emailing it, faxing it over to someone else to take a look at. They can pull the KTRACS report themselves. So we would just encourage you to absolutely discuss the KTRACS report with the patient. That's an absolutely appropriate use. Let them know that you're using KTRACS and why you're using it. But maybe just document in the patient's chart that you did check KTRACS and then anything that you may have considered that day. Okay, now I'll let Jenny close us up.
No problem. So yeah, great questions. And again, I'm sure that Gail will be happy to answer any others. So thank you for joining us here today and for this particular session. I hope you've enjoyed the conference so far. And don't forget to just use this platform as much as you can to connect with others and get all the information that you might need. And I hope you all have a great day, and we'll go ahead and end this session. Thank you.